So my name is Scott Friedman. I'll be co-chairing this session with my colleague and former trainee, Vlad Ratsiu. I'm deeply honored to be here. I want to thank Professor Gheorghe and her colleagues in particular. I'm very proud of the fact that three of the very best trainees I've ever had the privilege of mentoring are Romanian. One is sitting here, Costa Galaman. Another is Professor Ratsiu, who was my second fellow in my laboratory. A third is a transplant hepatologist formerly at Mount Sinai, Dr. Carmen Stanka. So thank you very much for the honor of being here. I was asked and will be delighted to present some information on what are now landmark trials in NASH and fibrosis. In doing so, I'll be reflecting on a lot of interactions I have with companies, mostly biotech companies that you see listed here. I'll be happy to talk about this more after the session. So when we think about scarring, and I think Professor Bonino, the first speaker, emphasized this very nicely, which is that inflammation and injury in liver from whatever cause drives fibrosis. In our world, this is primarily viral hepatitis, non-alcoholic steatohepatitis, and alcohol. But of course, there are many other drivers of fibrosis. In our world in 2019, NASH has arisen as the largest single population at risk for fibrosis, even though worldwide viral hepatitis still remains the largest threat to liver health. Just to remind you, non-alcoholic fatty liver disease is a spectrum of hepatic pathologies. It begins with fat in the liver, and in some patients can progress to NASH or non-alcoholic steatohepatitis, and once this is present, then cirrhosis can develop and may be complicated by hepatocellular carcinoma. So one important point here is that steatosis alone, while it can precede NASH, is not an indication for liver-specific therapy. And none of the clinical trials that I'll be reviewing shortly address treating fat alone. And the the Food and Drug Administration, or FDA in the United States, has made clear, as I suspect as EMEA, that we do not want to treat plain fat in the liver, at least not with liver drugs. That it is the non-alcoholic steatohepatitis patients, or NASH, that are the patients who are at risk for progression to advanced fibrosis, cirrhosis, and hepatocellular carcinoma. When we assess the response to drugs, one of the most common scoring systems is shown here. It's the NAFLD activity score, and it is comprised of three components: fat or steatosis, lobular inflammation, and hepatocyte ballooning. It's very interesting that these scores, these criteria for scoring biopsies were developed not because they are the most predictive of fibrosis, but rather because they were the features on biopsy that pathologists could agree on the most. They had the highest kappa score. And as it turns out, although I don't have time to review the data, these features and their improvement do not specifically predict an improvement or worsening in fibrosis. And so increasingly, clinical trials are focused instead on the fibrosis score as a readout of efficacy of drugs for NASH. And that's underscored by this slide here. This is now a landmark study that was published by Zubair Yanasi and Zach Goodman and others that looked at the natural history of fatty liver disease based on the original or the initial fibrosis stage. What you can see from the solid line is that when the fibrosis stage was stage 4, the mortality or the survival probability dropped precipitously over a 300-month period. When patients had no fibrosis, their outcome was excellent. And so ultimately, when we assess the activity of antifibrotic or NASH therapies, we need to establish whether there is a direct or indirect improvement in fibrosis. One other point that I alluded to before that's very important is the rising risk of hepatocellular carcinoma in NASH. This is a study from another of my very talented trainees, Helen Reeves, who's at the University of Newcastle. What you're looking at is the number of HCC cases who were referred to their center over a 10-year period, and within each year, the different etiologies are distinguished by different colors. What's most striking is not just the increased number of referrals, but more importantly, the growing fraction of patients, which you can see as orange in the bar, which represents an underlying etiology of non-alcoholic fatty liver disease, or NASH. such that 9 years ago, and this of course is now outdated, 9 years ago fatty liver disease accounted for over 34% of the cancers that they were seeing. And what's especially worrisome is that the risk of cancer appears earlier in this disease progression than viral hepatitis. So whereas viral hepatitis C generally has about a 15% risk of cancer in non-cirrhotic patients, the risk of cancer in non-cirrhotic NASH patients is at least twice that, 30 to 40%. And this has been borne out by several studies that all suggest that patients with NASH are at higher risk for HCC when they are not yet cirrhotic. One other important point was in this study, one of the known polymorphisms that associates with risk of NASH, PNPLA3, is also associated with a heightened risk of hepatocellular carcinoma in patients who have NASH. So a key takeaway is the sensitivity for a risk of cancer earlier in the disease than what we see for hepatitis B or C. So let me take a minute to review some of the features of fibrosis and the pathophysiology based on work that's been done in my laboratory and others over many years, and that will allow me to move on to some of the clinical trials, and I'm sure Professor Ratsiu will return to these concepts in his talk at the end of the session. So for many years, 35 years in fact, we've been interested in the hepatic stellate cell. That's the cell shown here in blue color. In normal liver, it is a pericyte cell, and it is characterized by storage of vitamin A as lipid droplets that you see surrounding the nucleus. Characteristically, when the liver becomes injured, stellate cells become activated, and they are associated with the accumulation of fibrosis that you see here developing in the subendothelial space between hepatocytes and sinusoidal endothelial cells. And this early accumulation of fibrosis in the sinusoid was termed capillarization of the sinusoid by Popper and Schaffner over 50 years ago. This early event is a tip-off that there is more fibrosis to follow, although we recognize this is still reversible. So from that early understanding of stellate cell activation, we have been able to create more of a broader understanding of how stellate cells activate. And typically in parenchymal liver disease, such as NASH or viral hepatitis, early injury occurs to epithelial cells or hepatocytes. This leads to early activation of stellate cells, and from that follows a whole cascade of events that drive fibrosis. That includes proliferation of cells, contractility, increased fibrogenesis for these cells, altered matrix degradation, directed chemoattraction of stellate cells, and enhanced inflammatory signaling. So all of these events together conspire to make more scar and enhance inflammation. More recently, animal studies have begun to ask what happens in the case of fibrosis regression. For example, in the first speaker today, Dr. Bonino, talked about the fantastic effect of antiviral therapies for hepatitis B on regression of fibrosis. So what happens to activated stellate cells when the liver no longer makes scar? So animal studies indicate that there are at least two pathways. One is that the cells can undergo programmed cell death or apoptosis. Another, studies from Tatiana Kiseleva and Robert Schwabe underscored the possibility for activated stellate cells to revert to a more quiescent phenotype. And so ultimately what we're trying to do is remove the number of activated stellate cells through one or both of these pathways. We have also begun to understand in great detail the cellular and molecular events that occur during stellate cell activation. I won't go through this slide in any detail, but it illustrates the many receptors and intracellular pathways that have now been described during stellate cell activation. And it's very exciting for those of us who have been studying the cell for many years to recognize that virtually all of these molecules represent targets for antifibrotic therapy. And so many of the trials that I'll be describing in more detail momentarily really leverage our increased understanding of stellate cell activation at the intracellular, at the nuclear level, and at the membrane receptor level. One of the ways one of the challenges, I should say, is as we move towards clinical trials, how do we know if a drug in NASH is working? We can't do a viral load, we can't do a PCR, we need to generate information directly or indirectly from the tissue itself. And this currently represents probably the biggest challenge to drug development for NASH. It's not the availability of new targets or drugs. We have many of them. But all of the clinical trials that are nearing FDA or EMEA approval have to be based on liver biopsy, which, as you all know, is very invasive and is prone to sampling variability. So what are some of the newer diagnostics that we can think about? There are lipidomics that are being developed that can distinguish plain fat from inflammatory liver disease. FibroScan, of course, is widely available here in Europe as well as in the United States and India, China as well. And now this is useful for clinical management, but FibroScan is not sensitive enough to serve as a primary endpoint in an antifibrotic or NASH therapy trial. There are, however, new MR technologies such as MR elastography, MR fat fraction, perspective-corrected T1 weighted imaging. All of these, I believe, are going to continue to advance, and ultimately we are hoping to develop one or more technologies that can replace biopsy. However, we are not there yet. Hepatic venous pressure gradient, you heard a question from Professor Sareen, and he is also a world's expert in this. This, of course, is a very sensitive test to assess the risk of complications of cirrhosis, but it is, in fact, very invasive. So as we think about developing therapies in NASH for hundreds of thousands or millions of patients, we can't rely on HVPG as a standard diagnostic. And then finally, there are actually some novel tests that rely, rather than the structure of the liver, they rely on assessing the function of the liver. And this is something that's very familiar to pulmonologists, for example. When pulmonologists are testing new drugs for pulmonary fibrosis, they are not biopsying the lung to look at the amount of collagen. They're assessing forced expiratory volume in 1 second, forced vital capacity, 6-minute walk test. These are all functional tests of lung. And by analogy, we are increasingly looking to develop functional tests for liver by assessing and quantifying the metabolic reserve. And so as you assess clinical trials coming out next week at EASL, you'll begin to see some of these technologies being presented. One in particular from a company in Colorado called HepQuant was conducted in association with the obeticholic acid phase 3 trial from Intercept called Regenerate. And there is a poster at EASL next week that will be looking at the correlation between the HepQuant function test and response to obeticholic acid. So these are early days, but stay tuned for new non-invasive methods that can determine whether a drug in NASH is effective without having to do biopsy. Of course, you already heard the exciting news, and you know it as clinicians, that hepatic fibrosis is reversible. For those of us who studied years ago, this is an astounding advance, because we were taught that by definition, when a patient had cirrhosis, it was irreversible. And of course, that was true 40, 30 years ago, because there were no treatments for liver disease except for corticosteroids. But now we recognize with good antivirals that the liver has tremendous regenerative capacity and that it can resorb an enormous amount of scar. So although there are no specific antifibrotic therapies, we know very well, and you saw data earlier, of the power of treating the underlying disease, which ignites an endogenous program of fibrosis regression and reduced inflammation. And it tells us that the liver has innate pathways to resorb scar. And one of the advantages is we can look to ask, what does the liver do naturally to resorb scar? What cells are amplified? What mediators are degrading scar? And these are questions we're just beginning to tackle now as an insight into developing antifibrotic or matrix-degrading therapies. And even cirrhosis is also reversible, although as you heard from Professor Bernino, I think the words of Professor Desmet were very, I would say, very prescient, because we still don't know the point of no return. That is, when is cirrhosis just simply too late to reverse? And I believe, based in part on Professor Desmet and our own studies in animal models, once an animal has developed portal hypertension with severe distortion of the vascular spaces, vascular extinction, intrahepatic shunting, you may be able to regress scar, but it becomes less and less likely that that will reverse the entire liver disease and restore a normal architecture, which can occur in earlier stages. What do we know about reversibility in NASH? This is based largely on the pioneering work of Philippe Mathurin and his colleagues in Lille and throughout France, who have been looking at the effect of bariatric surgery on NASH. This was a study several years ago looking at the changes in histology 1 year after bariatric surgery. And what you can see based on NAFLD activity score is that there's a dramatic decrease in the number of patients with advanced NAFLD activity score 1 year after bariatric surgery. If we look in those same biopsies at the improvement in fibrosis, it occurs as well, although it's more modest. So it goes from 32% advanced stages to approximately 23%, 24% of the patients. And this is not surprising. This is similar to what's been seen in hepatitis B, where we know that inflammation and injury must resolve first. There must be attenuation of damage, and then the liver antifibrotic and regenerative program will become more evident. And so we're awaiting the 5-year data from Professor Mathurin to find out how much additional benefit there was 5 years after bariatric surgery, assuming that patients continued to lose weight. Speaking of weight loss, I'm going to give you a whole list of therapies, but it would be negligent of me if I didn't start with the most fundamental and most effective therapy for NASH, which is weight loss. So if you were to make a grid or a chart and looked at which drugs affect which major features of NASH, the only intervention that would affect all the features of NASH favorably is weight loss. Of course, we know that weight loss can be achieved. The challenge, for a variety of reasons, is to sustain weight loss over a long period of time. Long-term weight loss regimens have a less than 5% success rate, even though short-term weight loss is something that's readily achievable. These are data from a study performed actually in Havana, Cuba, by a very talented scientist who now works at the University of Indiana, Eduardo Villar Gomez. I was peripherally involved in this study. And they did a 1-year controlled diet program with biopsies at the beginning and the end. And rather than go through the data, please focus on the blue and white box at the bottom. What their data suggested based on biopsy was that a 5% weight loss will improve fat, a 7% weight loss will improve hepatocellular ballooning, which we believe is probably the single most important feature of the NAFLD activity score in predicting outcomes, and a 10% weight loss will yield fibrosis improvement. So when managing patients with NASH, we need to encourage them that we're not trying necessarily to motivate them to a huge weight loss. Even modest amounts of weight loss can have a significant effect on biopsy and perhaps on the long-term outcomes of NASH. So modest or moderate weight loss is certainly a relevant and important goal. And I think it's safe to say that if there is a pharmacotherapy or any effective therapy for weight loss that is long-term, durable, sustained, and significant, much of the NASH that we'll be treating in our practices will go away. But let's go on to some of the pharmacotherapies that are being developed, because there are literally hundreds. I'm just going to summarize in broad strokes and give you some examples of some of the clinical trials that are underway. If we look at the pathogenesis of NASH, it really starts with injury to hepatocytes through accumulation of fat, insulin resistance, and altered immunity. And for this approach, there are a number of targets. So what I'm listing here are not drugs. I'm listing specific metabolic or molecular targets that are currently in development for clinical trials. Most of them are antagonists, although in the case of FXR, this is an FXR agonist. So there are a number of drugs that are intended to attenuate fat accumulation in the hepatocyte, yet other drugs, in particular GLP-1 agonists and receptor agonists and SGLT2 antagonists, these are potentially very exciting because they treat the diabetes, and in the case of GLP-1, they also yield significant weight loss. And it may well be that much of the benefit of GLP-1 agonism will turn out to be because these drugs induce some weight loss. There are also a large number of inflammatory targets, all of which are currently being developed as targets for NASH therapy. There are drugs that are also directed to the mitochondrion. So the mitochondria is an important source of energy for the healthy cell. Generation of oxidant stress comes about through dysregulation of mitochondria, and there are drugs that are intending to attenuate the damage and the dysregulation of mitochondria as a metabolic therapy. And then finally, there are many drugs that I'll show you in a moment that are also directly antifibrotic by reducing activation of stellate cells. Now you'll notice that a number of these targets, for example, FXR, PPARs, are in more than one category. And that is an appealing feature of many of these drugs because, for example, FXR agonism, CCR2 antagonism have both metabolic benefits, anti-inflammatory benefits, and at the same time they may also have antifibrotic benefit. And so companies are looking to develop drugs that have more than one target of action as a way of attenuating many steps in the disease process. I mentioned there are a whole host of specific antifibrotics. This is from a review that my colleagues and I wrote in 2015. It's in Gut that you can see at the bottom of the screen. Certainly controlling the primary disease is a major approach, but there are also receptors that drive fibrosis and inflammation. There are specific molecules that are turning off the fibrogenic cytokines like TGF-beta. Those are in very, I would say, advanced development. And then finally, there are therapies that also promote resolution of fibrosis. So what I want to leave you with is that there are a tremendous number of opportunities based on our understanding of the molecular biology of fibrosis. And because of the opportunity in terms of the unmet need, there are literally hundreds of companies now that are developing drugs to target many of these molecules and the ones on the preceding slide. In fact, here's a list that's now a little bit out of date that was generated by my colleague and friend Naga Chalasani. It's looking at all the different drugs that are in clinical trials as of 2018. The phase 2 and phase 3 drugs are on the right, the phase 1 drugs are on the left. I'm not going to go through this, but it's really just to give you a sense of how many drugs now are being developed by the biotech and pharmaceutical industries, both new drugs that are developed especially for NASH, but at least in half of the cases, drugs that have been available for other indications that upon retrospect may also have activity in NASH, and this is known as drug repurposing. Drug repurposing has the advantage of already having accumulated safety data in patients so that it can move directly to phase 2 or phase 3 trials, and many companies are pulling drugs off of their shelves that they decided not to develop for other indications and are now revisiting these old drugs as new indications for NASH. We got into this earlier than I could have imagined. We were approached by a small company called Intercept, which had one employee at the time, Mark Pruzanski. In 2003, he approached my laboratory and asked if we could test a new drug that he thought might be useful as an antifibrotic. That drug now is known as obeticholic acid. It is a ligand for the FXR receptor. These are studies that we performed in my laboratory and presented at AASLD in 2005. On the left-hand side, you can see the gross and histologic picture of advanced cirrhosis in a rat due to thioacetamide. On the right-hand side are the corresponding livers and microhistology in an animal that was treated with obeticholic acid in the setting of this advanced cirrhosis. More recently, this has been replicated in a very large and very well-conducted study from a Belgian group that showed exactly the same result, and that the fact that the drug also reduced portal hypertension. So this was in 2005. If we now take a look at all the ways this drug can affect fibrosis and NASH, you can see that in principle, obeticholic acid has many attractive features that would make it appealing as a NASH therapy. It can improve liver fat, improve adipose biology, improve insulin signaling, as well as skeletal muscle homeostasis. And so from that early animal study, if we now look at the first clinical trial that really made news, this was in 2012, I believe, or 2013 rather, January 2013, the so-called Flint trial. This was a trial conducted, it was a phase 2 trial looking at the biopsy response to obeticholic acid after 18 months of therapy in patients with biopsy-proven NASH. What was most striking is that there was a doubling in the number of patients who had an antifibrotic benefit. And so this really almost was the spark that lit the whole field on fire, because the business as well as the scientific community began to realize that NASH was an unmet need and there was a therapy that might actually be beneficial. So the company went on to do a phase 3 trial. Full disclosure, I've consulted for the company, as you can imagine, for many years. These are the phase 3 data in their so-called Regenerate trial, the results of which will be presented at the EASL meeting next week in Vienna. This was very similar to the phase 2 trial. It was a trial in patients with NASH stage 2 or 3 fibrosis. And the primary endpoints were either a fibrosis improvement of 1 stage or greater with no NASH worsening, or NASH resolution with no worsening of fibrosis. And as you can see on the top line, there was a significant improvement at the higher dose of obeticholic acid, 23%. Remember, the phase 2 trial was 35% more or less. The phase 3 trial is 23% of patients responded at the higher dose, 17.8% at the lower dose, 11.9% placebo response. And this is also an important point. One of the biggest challenges in NASH trials has been the very high rate of placebo response. And while we don't have a scientific explanation, the best we can come up with is that patients who have a weight-sensitive disease will change their lifestyle, even though they're encouraged not to do anything differently, but merely the fact, even on placebo, of coming to the doctor or the coordinator once a month may impact on activity sufficient to have a placebo response. And so one way to mitigate that, we've learned, is to try to favor the inclusion in these trials of patients who have elevated ALT and more advanced disease. You can see that the drug did not hit the primary endpoint of NASH resolution with no worsening of fibrosis. But of the two, I suppose one could argue fibrosis improvement is a more critical one for disease progression. But even here, only 23% of the patients in the high-dose drug group had a response. That's wholly inadequate as a final end or a final answer to NASH therapy. It's simply an entry point or evidence that there's some drug that can have some effect. And if we look back to the history of hepatitis C therapies, it's clear that it took 25 years to go from a 5 to a 10 to a 25, 50, 75, and then 95% response rate to antivirals. And it's very clear that NASH will also have an incremental story where benefit is accrued incrementally with adding new drugs, combining drugs, finding better drugs. But it is evidence on the positive side that a drug can change the histology of NASH, and that's good news. It's not without side effects. There was although the overall frequency of adverse events was similar across all arms, there was clearly and predictably dose-related pruritus that was significant, up to 51% in the obeticholic-treated, OCA-treated patients at high dose that required discontinuing of the drug at 9%. There was also a predicted increase in LDL cholesterol. However, by the end of the 18 months, the LDL cholesterol between the treated and the placebo groups was equal, and this may be in part because physicians in the study were encouraged to use statins to normalize LDL if there was an increase in response to the drug. So early good news, long way to go. Another drug that is in clinical trials is aramocol. This is a conjugate of a fatty acid and a bile acid. It's developed by an Israeli company called Galmed. And we know that this drug can actually reduce liver fat. That's been shown in a phase 2 trial, and actually Vlad Ratsiu is the international PI on this trial. And it's very well tolerated, so this may become a useful drug for combination therapies because there's effectively no side effects that we're aware of, but of course it requires phase 3 studies. I mentioned the GLP-1 agonists. These are especially appealing because of their propensity to induce weight loss. This is the result of a very small trial, but of course is now being followed by much larger trials. As you can see here, liraglutide is a GLP-1 agonist. There was, compared to placebo, in 23 patients in each group. We know that there are hundreds of patients being enrolled in larger trials. And again, GLP-1 agonists have the appeal of reducing liver fat, inducing weight loss, and improving glucose homeostasis. So these may turn out to be a very attractive backbone of therapy, although in this small trial there was an increased risk of diarrhea with the drug. Another drug that has been tested in phase 2b trials is an antagonist to the chemokine receptors, CCR2, CCR5. It's known as cenicriviroc. It was developed by a small company called Dobira that has now been acquired by Allergan. And what they showed at 1 year was a doubling in the antifibrotic response rate based on biopsy. Now, this is a complicated study design. What was interesting is that at 2 years of therapy on the drug, the benefit did not accumulate further. It was only about 22% in the treated groups for 2 years. So it looks like most of the benefit that occurs from drugs will occur within the first year. What happened in the second year was that placebo group went up to about 17%. And so the results were not significant at 2 years as they were at 1 year, not because the drug wasn't as effective, but because the placebo group started to improve. I don't have that data here. So this is an anti-inflammatory. What was interesting is that it improved fibrosis with no change in the histologic score of inflammation. So still lots of mysteries about why an inflammatory drug will improve fibrosis without improving histologic inflammation. And we'll learn more about this over the years. A drug developed by a French company, Genfit, and again, Vlad Rațiu was the PI on this trial. It's an agonist for two PPAR receptors, PPAR alpha and PPAR delta. It's thought to have dual activity in both macrophages, where it's anti-inflammatory and anti-fat accumulating in hepatocytes. And this was the phase 2 trial that Vlad was the PI, called the Golden Trial. This turned out to be a very interesting trial because they enrolled patients who had early stage NASH with a NAFLD activity score of 3 or greater rather than 4 or greater. And it turns out in doing so, the results were no longer significant. However, if they had removed post hoc, if they had removed from the analysis patients who had early NAFLD activity score of 3 or greater, the drug would have been effective. And this drug is now well into phase 3 trials, appears to be well tolerated, has multiple beneficial effects on fibrosis and fat, as well as potentially inflammation. We'll hear more about this over the next several months. The results from the phase 3 trial should be released later this year. This is an interesting drug because it was thought to be very exciting based on these data that showed that it could improve fibrosis within 6 months. But without going into detail, what I want to emphasize is this was a poorly designed phase 2 trial that wasn't really placebo controlled. This is a drug from Gilead that blocks a molecule called ASK1. They used it in combination with a drug called simtuzumab. However, it turns out simtuzumab was ineffective. And so they looked to the groups that had 18 or 6 milligrams of drug plus simtuzumab and showed that the results in biopsy were much better than simtuzumab alone. And so they assumed that this drug was effective, and they went on to a phase 3 trial in cirrhotics. And those results were released 2 months ago. They were completely negative. So in a way, although the non-cirrhotic trial is still ongoing, that may show some benefit. It also underscores that a poorly designed phase 2 trial should not be used as a justification to move on to a very rigorous, large phase 3 trial. Another drug that's gotten a lot of attention is shown here. This is a drug that is the thyroid hormone beta selective agonist. So thyroid hormone receptor has different isoforms. It turns out if you agonize just the beta subunit, you have no impact on overall thyroid hormone homeostasis. But without going into the detail here, this reduced liver fat significantly. And so this thyroid hormone beta receptor agonist is now moving towards phase 3 trials to reduce liver fat. It does not appear to have a mechanism for direct antifibrotic benefit, but there appeared to be an indirect benefit on fibrosis in this trial. Finally, there's a drug called NGM282. You'll hear about this also at the EASL meeting next week. This is a very clever molecule that has been engineered to remove some of the mitogenic effects of the drug and to sustain the anti-steatotic effects. They did an amazingly heroic trial of 3 months and showed 42% histologic improvement in 3 months in response to this drug. However, it raises LDL cholesterol, but also requires daily injection. So I've given you a rapid overview, but it's clear that with the best drug we have in phase 3, only improving 23% of patients, we need to start thinking about combination therapies rather than single agents. Here's some considerations. Drug combinations, although we haven't defined what are the best ones, can cover many different targets and sort of hedge the bets in absence of clarity about pathogenic events. What I mean by that is we don't know which pathways in NASH are absolutely critical to development of disease. We don't know what the Achilles heel is of the disease, and so we don't know which target to pick. And we have dozens and dozens of different targets, and we cannot prioritize which one is most attractive. Certainly, an appeal of a single drug is it's easier to get through regulation and safety data, whereas if you have two new drugs, you can't combine them unless you show that each one is safe and effective as an individual drug. And then finally, in single therapies, the drugs that are favored are the ones like FXR agonists and PPAR agonists because they have multiple targets even though they're a single drug. There are approaches one can use that have not really been leveraged yet to develop rational basis for drug combinations using transcriptomics, and I've advocated for that with many of the companies in the field. So these are early days, no question, however, we're going to move towards combinations. I'm not going to go through the data here because it was very disappointing, but already Gilead is trying combinations with its different drugs. This was the trial design, and without showing you their early data, I can tell you there was no synergy in any combination yet. So it's not so easy as just taking any two drugs and adding them together and assuming that that will yield a beneficial or a synergistic effect. So let me summarize so we have a little time for questions. I think studies of hepatic fibrosis and NASH have, of course, reached clinical trials. For those of us who've been working on this in the laboratory since the early 1980s, this is enormously gratifying. I also need to remind you that cancer risk is elevated in NASH, and mechanisms are emerging that may be disease-specific for NASH that are different than other diseases. The framework of stellate cell activation that we proposed many years ago still is quite useful. It provides many, but not all of the targets for antifibrotic therapies. From a drug development perspective, NASH is by far the biggest population that the companies in this field are going after, although there are exciting new developments in primary sclerosing cholangitis and PBC, as well as neonatal liver disease. Fibrosis regression may be possible in NASH, and that may require either direct or indirect antifibrotic or inflammatory approaches. We've seen fibrosis improvement both with and without associated NASH improvement, and this can occur in as little as 3 months based on the NGM trial. So really exciting that the fibrosis can be pharmacologically managed within a very short interval. And then finally, there's no question that we're moving and have already started to move towards combination therapies so that we can effectively improve outcomes. And one final point, which is that even when we do liver biopsy, it's worth remembering that a liver biopsy is considered a surrogate endpoint because liver biopsy improvement doesn't guarantee that patients will have less portal hypertension, less variceal hemorrhage, ascites, encephalopathy. So even the drugs that will be improved, that might be approved based on a biopsy improvement, will be required to continue studying the long-term effects. The FDA and the EMEA will insist that drugs that improve the liver biopsy and get approved still have to go on to show that they also improve liver outcomes, not just liver biopsies. So I hope I've left with a sense of the excitement in this field. We have a long way to go, but we've certainly covered a lot of ground, so I would call this the end of the beginning in NASH therapies. I want to thank Professor Georgi again and her colleagues. It's been an honor to be here. Thank you. I guess we have time for a question or two. Vlad, you have a question?
Yeah.
What?
Yeah.
You want to wait for the end? Sure. Are you the next speaker?
So thank you, Scott. This is a fantastic overview. And since Scott was kind enough to mention my name several times, I also have to disclose that everything I know about stellate cells, I learned it from Scott, or at least the part I still remember. And the other thing is that he also taught me how to make nice slides, you know, by doing them in a way that, you know, in an economical way and only put important things on the slides. But now I realize all this is useless because now here comes Scott that shows up with artist-drawn slides, and I think I can never match that. So thank you again, Scott. I think the next speaker will touch about a very important topic. This is Costica Aloman, which of course is also born in Romania now, works and conducts his research at Rush Center in Chicago. And he'll try to explain us what makes the difference between men and women in terms of susceptibility to alcoholic liver disease. We've known this is a very important topic since women can have even cirrhosis at a much lower levels of alcohol consumption, and he'll try to explain to us whether there are immunological bases that account for this difference. So Costica, the podium is yours.
Thanks so much for the invitation to this meeting. Is my fourth time here, and actually, I'm honored because actually two of my mentors, actually Dr. Georges, both of them, and Dr. Friedman actually show me the path in the hepatology, one from the clinical perspective and the Dr. Friedman from the basic science perspective. And I will try to go to exemplify actually how we start from the preclinical side to develop, actually to understand a path to develop a new targeted therapies for a disease. And actually my research, I'm a cellular immunologist, and from the basic research perspective, I'm a transplant hepatologist on my clinical side. So I will try the question that I was interested to address is actually why the women are more susceptible to alcoholic liver injury. And actually I had to retake the board for the transplant hepatology. We have to do this every 10 years, independent too much of the level where we are in the United States. And one of the board questions was why the women are more susceptible to alcoholic liver injury. And actually the answer to the question, it was actually because the alcohol metabolism and the body composition of the woman is different than men. And I was not very happy. I learned actually how to look and to see what is the evidence for that in the literature. And because I'm a cellular immunologist, the first thing that came in my mind, why not immune system is responsible for that? Because actually we know pretty well that immune system in women and men are different. Actually, the men are supposed to fight with the infection, and the women, they have an immune system that actually is shaped to downregulate the immune system. So, and this is actually especially evident at the level of the cytokine production. And these are only like few of the articles. If you are going to do a PubMed and to look on the immune differences between men and women, there are major differences at different cellular types that actually is going to tell you what is the difference between men and women. So this is my question that I try to address, and all the time when I'm trying to do something in my lab, I start with the clinical question, I go back to a preclinical model, and I validate in humans. And actually I'm going to show only the first part because I don't have time to go to all the steps. This is the clinical question that I try to address. There is a specific, sex-specific dimorphic effect of alcohol on hepatic immune cell homeostasis. The first thing that you have to think, okay, what model I'm going to use? And there are actually 3 models of chronic alcoholic exposure in mice, and one of them, the simplest one, is basically to let the mice to drink alcohol from the water. And it's pretty straightforward. Actually, the hepatologist and actually the people who are doing the clinical investigation in the hepatology, they don't like too much this model because actually it doesn't give you too much histological changes. Give you a little steatosis after like 1 to 3 months of alcohol consumption, but not too much inflammation, nothing else on the histology. However, immunologists, they love it, and actually these are four of the papers that actually they use this model. And the second model is actually Liber-Di-Carli diet that use actually a liquid diet high in fat and actually adding on alcohol, and it's isocaloric. And actually this is the most extensive diet that is used to explore the effect of the alcohol in preclinical model. However, and this is the model, actually Liber-Di-Carli diet is the model that I used even before in my previous papers. But actually what I learned when I explore at the level of the cellular level, at the level of the histological level, and this is an example of the, at the level of the transcriptional level, that when you compare these 2 diets, additional fat, when you increase the fat with the alcohol, completely read the transcriptional profile at the level, transcriptional profile of the liver of these mice, suggesting that if you want to look at the specific effect of the alcohol in preclinical model, probably still the best model is actually to add on the alcohol to the solid diet of these mice. So for this reason, actually, I was able actually to convince the NIH that actually using this model to explore the immune effect of the alcohol is the best compared with Liberty-Curly diet. So what's happening with the mice when you feed them male and female mice if you feed them with the alcohol? Basically, after 4 weeks, they develop actually some hepatomegaly that is actually exemplifying increasing liver body weight ratio, and it's reaching statistical significance actually in female. The male, actually, there is a trend, and you see there the numbers actually that we use for this experiment. There are quite a high number of mice that they're used. And when you look on the histology, actually, you notice that actually there is development of small droplet steatosis in alcohol-fed female mice. And these are very early changes. Actually, if you continue, if you remember, like 2 years ago, I presented the data actually for 3 months exposure to this diet. Actually, the steatosis is more pronounced. So I'm interested, I'm a cellular immunologist, so actually I'm interested, okay, what's happening with the immune cells in the liver? And very interesting, if you look on the histology on the liver of these mice, actually you don't see too much differences. But our eyes have a sensitivity, actually, you can see the inflammation in the liver of the mice if you actually, the sensitivity is around 10 to the 7, like 10 millions of cells per gram of tissue. So actually, whatever it's actually normal, a normal murine liver has around 1 million, 2 million of cells. So actually 10 times, in the range of 10 times increasing the inflammatory cells in the liver, you're not going to see it by eyes. So for this reason, actually, we use polychromatic flow cytometry to identify early changes in the inflammatory cells in the liver. And actually, after 4 weeks, actually, there is not too much change. There is a trend in the females, but there is not a change in the absolute number of the cells. But all the time, the male, they have a lower number of the inflammatory cells compared with the females. When you look on the composition, we're interested in the myeloid cells. Very interesting, actually, the neutrophils and dendritic cells, they are not changed, but actually only in the female mice we have increase in the monocytes. There are 2 subsets of monocytes, and actually this is a very hot topic, especially in the liver fibrosis, because it was shown that actually these 2 subsets, they modulate differently fibrosis regression. And the marker that is used to make the difference between these 2 subsets of monocytes, they are actually, it's this marker LY6C. And if you compare the LY6C positive monocytes and LY6C negative monocytes, actually the majority of the increase in the monocytes in the liver of these mice is due to actually to LY6C monocytes in the liver of the female mice. This change is not observed actually in the male mice. And because all the time I learn whatever you see by polychromatic flow cytometry has to be validated by images, actually I like to do at the level of to see at the level of immunofluorescence actually this change. And actually I stand for LY6C positive cells and F480 positive cells, which is a marker of the monocytes. And actually F480 positive cells, that is a marker of the monocytes, you can see it in red. In green, it's LY6C positive cells. And actually what you have to pay attention only to these 4 squares. And as you can see, there is less green in the female fed with alcohol compared with the female control. And if you go back and look on the control and alcohol, male mice, they are the same type of color, the same amount of red and green. There is this increase in the monocytes specific to the liver, and if you look in the lung, kidney, and spleen, so lymphoid and non-lymphoid organ, actually, you can see that if you count all the cells, and this is significant amount of work done by one of my postdocs in the lab, actually show that there is not a difference in the cells, in the monocytes in the lung, kidney, and spleen at the level of the set and subsets. And similar for the male mice, actually there is an increase in LY6C negative monocyte. There is some increase in LY6C negative monocyte, but it's in the kidney, and I don't know exactly what is the significance of this, but in the liver, basically, you don't see it. The next question that you try to address is actually why this is happening. Why do you have an increase in LY16 negative monocytes in the liver of the female mice fed with alcohol? And actually, the first thing that you have to think, maybe the driver of the monocyte development is actually increased. And actually, it's exactly the opposite. If you check the MCSF, which is the main monocyte development cytokine, in the blood of the mice, actually the MCSF is decreased, it's not increased. If you look, actually, bone marrow function as a deposit for the monocyte, for the mature monocytes, and these are released under the stress condition. So if I'm looking to the mature monocytes in the bone marrow, actually they are the same. The alcohol doesn't change at all the numbers, set and subset. If you look on the progenitors, also the same alcohol, there are trends, but actually there is no statistical significance in spite of the numbers. So there is not a problem with the bone marrow in the female mice when you look in the bone marrow. So the next question you ask, okay, recruitment in the liver is affected, and this can be affected actually at the level of the endothelium due to change in the endothelial adhesion molecule or at the level of the chemokine gradient. And actually, this is a bunch of negative data. Basically, there is not an effect on the hepatic endothelial adhesion molecules, and the same. The chemokine gradient is not changed. So if I have to make a summary of this, my first part, it's actually, there is an increase in the hepatic monocytes by 50% in alcohol-fed females, early upon chronic alcohol exposure, largely determined by the increase in the LY16 low subset. This increase in the monocytes is not the result of the increase in the bone marrow reserve of monocytes or bone marrow progenitors. And it doesn't look like the alcohol is changing the recruitment of the monocytes in the liver by a chemokine gradient or increase in adhesion molecules. So, how do I find the mechanism for this recruitment of the monocytes in the liver in the setting of the alcohol consumption and to be only in the female? And actually, the link that I found, it's pretty well known that alcohol increases the intestinal permeability, and there are multiple papers there. The first one that is mentioned there in the FASEB, it's only one of them. And I found a very interesting paper actually showing that actually type 1 interferon drives the inflammasome-independent emergent monocytopoiesis during endotoxemia. And this was very interesting because it's pretty well known that females, they have a higher interferon alpha production. And this is responsible why the female, they have more autoimmune diseases. So I thought I'm going to try to find a knockout mouse that has a deficiency in the receptor for signaling of interferon alpha. And I'm going to repeat the experiments that I did with alcohol exposure. And I was lucky enough because when I repeated the experiments with interferon with the female, interferon receptor 1 knockout mice, actually, here you can see the plots for the monocytes. You don't see the same increase in the amount of the monocytes to the alcohol exposure. And in both subsets, LY60 positive and LY60 negative, suggesting the fact that actually recruitment of the monocytes in the liver, it's dependent on interferon 1 signaling in female mice. When I repeated this actually in the male mice, actually their experiments ran at the same time, it was actually exactly the opposite effect. So this was also, again, reinforcement that actually interferon 1 signaling actually has, it's in a way or other it's responsible of the mechanism of the phenotype in the liver. And I looked again on if the bone marrow monocytes are changed, and actually they're not affected too much by the alcohol in male and female. And at the level of the progenitors, the alcohol doesn't change in female and male. So In the summary, as a mechanism, the effect of alcohol on the hepatic LY6C monocyte in female is interferon 1 receptor dependent. And this fits actually pretty well with and links this axis of interferon receptor 1 monocyte axis with the alcohol effect on, first of all, as I mentioned, with the estrogen dependency. And it's linking also with my previous data and data that we are generating now in the lab related to PDC development and monocytes. And also the fact that there is in patient, there is some data there that actually there is an interferon alpha signature in the peripheral blood of patients with alcoholic liver disease that was never explained too much by the data that we have in the preclinical model. And actually there is quite a lot of data regarding the crosstalk and activation of the interferon alpha signaling tolerant receptor. Still, there are some questions to address, and this is how the interferon receptor 1 affects peripheral LY6C low monocyte pool. And actually, only to give you an idea, if it's not the central compartment is not affected, if the recruitment is not affected, probably it's something to do with the survival of the LY6C low monocyte, or maybe the conversion. And for me, it's very interesting, this conversion of LY6C positive monocyte and LY6C high from LY6C high monocytes, because this will provide a specific target, actually, for a small molecule, actually, to inhibit this conversion. And actually, what we are doing at the present time in our lab is to screen by RNA-seq analysis for the pathway that are involved in this change in the phenotype. So in the summary, I think I show you some data supporting the idea that interferon receptor signaling is important in alcohol-related immune effects, sex-specific alcohol-related immune effects, and this can be possible considered as a target for alcoholic immunopathogenesis. And how much is the contribution of this pathway compared, for example, with the intestinal permeability? Intestinal permeability in male and female, and I have the data for that, I don't have time to show you. It's a little different. Also, there is some data there that actually amount of the alcohol that the male and female mice are drinking are a little different. If this results in an exposure that is different, exposure to alcohol, we don't know, and actually we're exploring this in mice by doing LCMS for the phosphatidyl ethanol. And actually the metabolism rate is a little different between male and female, but the idea that actually there is something else than the concept that the body composition and the metabolism rate contributes to the sex differences, I think has to be taken into account even when you design a molecule, actually, to treat alcoholic liver disease, and also when you design a clinical trial. These are my acknowledgement. At the present time, I have only 2 people in my lab. Holger Feit was my former postdoc, and Alex Vogel, she went to the graduate school. I have only in my lab Dr. Miran Kim, who was actually, I have very exciting project actually in liver cancer, and Jibin Zhu is a visiting physician from China that actually came from 1 year, and actually it's working on the exposure, the differences between male and female regarding the alcohol exposure. I have 2 positions in my of postdoc in my lab, so if anyone from the younger people, younger residents who are doing their PhD thesis are interested, please come and speak with me, and I'm open for discussion. Thank you.
Beautiful work, Kostika. Maybe just 1 or 2 questions, and we'll save the rest for the panel. Maybe I'll just ask 1 question, then go ahead, please, Chief.
Very nice data. I was just wondering, did you measure the MCSF levels in the male and female after feeding alcohol? And did you compare MCSF with other GM-CSF or GCSF levels?
Correct.
That's part one. And part two, did you look at the cellular in the bone marrow? Did you look at the bone marrow niche, or did a proteomics of the bone marrow in males versus female animals? So did the alcohol as a toxin affect the bone marrow proteomics after feeding of alcohol?
So to answer to the first question, yes, I have the data actually regarding GM-CSF and GCSF actually in the blood and even in the bone marrow, and there are no differences actually. There are not the amount of the site of the growth factor is not increased to justify the monocytopoiesis. Actually, the same, they are decreased. And the second question, I didn't look on the proteomics, but actually I have a lot of I'm assessing actually, for example, the expression of CCR2, CCR5 at the level in the bone marrow to assess the egress of the monocytes, differential, if there is a difference between male and female, because this will explain also. Because I think CCR2 has an estrogen receptor promoter element, so maybe this will explain also the differences in the that I observe. Yeah.
I have a question here.
Thank you very much for your complex presentation. I did not understand everything because it's for well-initiated researchers, but I have a very simple question. Have you tried, escape from estrogen's influence, studying postmenopause living or to induce menopause in rats?
Actually,
Why to speak about estrogen when someone can believe it?
correct. So actually, this is in the mechanism part. Actually, that is getting. It's in the actually. If you try to look on the target, like actually we have designed the experiments actually, and actually I have in vitro data looking on the effect of the anti-estrogens, or for example in the monocytopoiesis in the plate, and actually the surgical procedure actually the easiest way to induce in this mice, I don't have the data here, it's actually to give them like anti-estrogens, yeah, and actually I don't have the data like with such an extensive high number, but looks on the preliminary data that you can replicate the data.
I think in the interest of time, we'll come back to more questions because I want to make sure we have time for the speakers. Thank you, Kostika.
Okay.
The next lecture is entitled Hepatocyte Plasticity in Vivo and in Vitro, Significance for Regenerative Therapies in Liver Disease by Professor Razvan Jacob.
Good morning. First of all, it's a great honor for me to be here today and to give this presentation in front of you and in front of our distinguished faculty. So I thought how to start this talk on regenerative medicine, and I thought back about talks that I have seen on this topic, and actually a lot of talks that I have seen start with a picture of Prometheus. Showing that even from mythological time, the ancient Greeks knew about the tremendous regenerative ability of the liver. And then I found a very interesting paper, editorial in JHAP, talking about another titan, the titan Tytuos, which had the same fate as Prometheus and was after that sent to Tartarus and tormented eternally by two eagles picking up his liver. So this clearly shows that the tremendous regenerative ability of the liver is known from the ancient times. Now, our liver has an extraordinary regenerative ability. We know that because it's able to withstand a lot of damage. It's able to withstand acute injury, may say it's a major hepatectomy or acute liver failure, but it's also able to withstand substantial chronic injury. It can be viral, toxic, autoimmune injury. In time, this will accumulate, and we have all these progressing stages of liver damage that start with minor modification and progress to advanced stage liver cirrhosis. The liver epithelium, as we all know, is consisting mainly of hepatocytes. 70 to 85% of the liver mass comprises of hepatocyte, which is it's a very interesting cell. It has a long life duration, 20 to up to 200 to up to 400 days. So the liver homeostasis is different to other organs. Now, everything resides in the liver architecture. As we know, the liver architecture is based on the polarized state of the hepatocyte. We have a very clear venous flow from the portal thread for the portal vein toward the central vein, passing to the sinusoids. We have the cords of hepatocytes that are lining the hepatic parenchyma, and then the biliary flow goes towards the biliary duct. We have this so-called canals of Herring, which are at the border where the hepatocytes meet the biliary cells. And of course, all the other cells that are important, the Kupfer cells, the stellate cells that have been mentioned. Everything is organized so to orchestrate a perfect liver function and to respond to every injury that the liver has to withstand. Of course, liver regeneration is a phenomenon that is present in all vertebrates and has basically a common basis. There's participation of the innate immune system, there's developing of ploidy, aneuploidy, tissue remodeling, and of course, there's a very tight control of liver volume at the end of the process, which is called the hepatostat. So the liver knows exactly how much to regenerate and how much to develop the parenchyma after an injury. There are studies that have shown that there's a specific cell proliferation order in the regeneration process. The hepatocytes are the one that orchestrate this, are the first to enter in the cell cycle and start to regenerate the parenchyma, then the Kupfer cells, the vascular endothelial cells, and the last, the biliary epithelial cells. Now, there are a lot of animal models that are used to study liver regeneration. I will not enter into too much detail. What I want to stress is that a lot of information that we have from liver regeneration comes from animal models, and animal models are not the same as the human setting. There are models, and the injury is induced by different ways, and it's possible that every model has a different way of supporting liver regeneration. The main research models for liver regeneration, of course, the most extensive one used is liver regeneration following partial hepatectomy, that there are hepatotoxic liver injury with different drugs. There is this pig model of acute liver insufficiency secondary to D-galactosamine diet. And of course, the immunodeficient fumarylate acetoacetate hydrolase, the FAH deficient animal model, which comes from the mouse animal model. And it's a very efficient model to study liver repopulation with different kind of cells. There are different phases of liver regeneration. We know the priming phase, we know the progression phase, and then the terminal phase with different mediators. Again, talking about the hepatostat, basically the liver index, so the liver weight to the body weight divided by 100 should not be more than 2.5. The majority of the growth factors, EGF, HGF, IGF, have a mitogenic role and inhibit apoptosis. Then a very important concept is the endo-reduplication process. It means the generation of cells with multiple chromosomal copies, which leads to augmentation of gene expression. And this is a process which is very important during liver regeneration. It's so to say, functional reserve for liver regeneration. And last but not least, the role of shear stress in the end of the regeneration process is very important. So during this regeneration process of the liver, a very important question is, are there any stem cells in the liver? Which cell population in the liver is the most important in supporting liver regeneration? And we have important lessons from the organogenesis of the liver. There are known endoderm precursors. There are known the hepatoblasts, which basically are bipotential cells that generate hepatocytes and cholangiocytes. There are animal models that have permitted to isolate resident stem cells at the levels of kernels of herring. But again, this is data from animal models. They have been used in vitro to generate hepatocytes and cholangiocytes, but we really do not know if this model also applies to the human setting. There are, of course, studies that have shown that there are non-hepatocyte sources that support liver regeneration. There are models that have shown that cholangiocytes by themselves can show a certain degree of plasticity, and they can generate hepatocytes and regenerate the liver parenchyma, but the percentage of liver parenchyma that can regenerate does not surpass 20-25%. So all the studies that have been done so far have indicated that the main cell in the liver that is responsible for liver regeneration is the hepatocyte by itself. And this is true for basal homeostasis of the liver. It's the same for acute liver injury or for chronic liver injury. The percentage of liver regeneration which can be attributed to other kind of cells, for example, to liver stem cells, it's below 2%. Now, another question is, are all the hepatocytes have the same regeneration potential and all of them participate in regenerating liver parenchyma? And the answer of this question are also studies that have been conducted in animal models. Some studies have shown that the hepatocytes that are around the periportal area are the one that can induce liver regeneration. And also some other interesting studies have shown that the hepatocytes that surround the pericentral areas, the Axin 2 positive hepatocytes, are maybe more important, especially when we talk to basal regeneration of the liver. And there's this very nice study published in Nature, in which the study group has used cell line tracing techniques to show that actually the cells that are around the periportal area are able to regenerate liver parenchyma, and also they behave like a stem cell and they preserve their own population. Now, what happens to hepatocytes in vitro? In vitro, it's interesting to notice that once you get the hepatocyte out of the body and put it in vitro, they de-differentiate, they rapidly de-differentiate. Basically, they preserve the function for a few days, and afterwards, they lose the liver-specific function and they de-differentiate. Of course, there are a lot of models proposed, a lot of cell culture conditions in which, starting with the hepatocyte population in vitro, you can generate different kind of cells that can be used for regenerative medicine. For example, you can use cells with progenitor abilities. For the human setting, of course, we have tried to see if what we find in animal model can be also used for human setting. And this is some work that we have done here in Romania using the protocol proposed by Professor Sarah Farber. Basically, you get hepatocytes from liver pieces, and you use a very simple model, so not try to get fancy culture conditions, just low glucose TMAM, and then the plate and weight techniques, and you start emerging after a few days a cell population that is rapidly proliferating and then can be substantially expanded. And we have tried to characterize this cell population. We thought, okay, what is this? Are these fibroblasts? Are these stem cells? What is this population? And we did qPCR studies for liver-specific transcription factors. What we can see is that we have compared here low passage cells with high passage cells, and we also used two different controls, fibroblast controls, F46, and also hepatocellular carcinoma control. And in terms of gene expression, we see that all these cells rapidly lose liver-specific gene expression. All liver-enriched transcription factors are massively downregulated. There are some endoderm factors like GATA4 and GATA6 that are still preserved in expression. Then with regard to cytoskeleton molecules, we see preserved cytokeratin 18, cytokeratin 19, but downregulation of liver-specific E-cadherin, then upregulation of EMT markers like vimentin and smooth methyl actin. Indeed, there is an increase in expression of EMT transcription factors, and the main players here are SLUG, TWIST1, and TWIST2. We thought maybe this is a reprogramming example. So we look to expression of reprogramming transcription factors, but we cannot support this hypothesis. There's actually downregulation of SOX2 and NANOG. And at the level of protein, we see that there is strong expression of cytokeratin 818, supporting somehow the fact that these cells come from the liver. You know that cytokeratin 818 is a liver-specific cytokeratin. Cytokeratin 19 rarely expressed in those cells. Smooth acyl actin, on the other hand, is strongly expressed, and also vimentin strongly expressed, showing that these cells actually undergo an epithelial to mesenchymal transition process. Negative staining for ecadherin, desmin, and keratin 19 is mostly negative. Then we look to mesenchymal stem cell markers, and we have seen that there's over 90% positivity for CD44, CD90, CD105, CD73. So then we say, hey, this should be mesenchymal stem cells. But when we look to our fibroblast population, we have seen exactly the same thing. So over 99, over 91% positivity for all these mesenchymal stem cell markers. The karyotype seems to be stable, but there's research still going on, at least for cells that came from patients that have not very advanced age, karyotype is stable. Now, what can be done with this kind of cells? First of all, they can be substantially expanded in vitro. So it's very important to be able to expand your cell population, because if you are talking about regenerative medicine and cell therapy, then you need a large amount of those cells to work with. What we have shown in this paper is that by using a sequential ectopic expression of liver-enriched transcription factors, you can remature those cells back to hepatocytes. You can regain albumin secretion, regain alpha-1 antitrypsin, you can regain urogenic ability, glycogen storage ability. Also, a very recent paper has taken somehow a similar approach, but they were focused on generating bipotential progenitor cells from hepatocytes, and then using those cells to get, again, biliary epithelium and liver epithelium. And then there's also this very well-known paper from Nature, in which it has been shown that fibroblasts, no matter if they come from liver or not, can be transdifferentiated to hepatocyte-like cells by using defined transcription factors. So what would be the clinical applications that basically exploit this great plasticity of cells? Of course, could be cell transplantation, could be generation of bioartificial liver devices. We can use those cells to try to cure inherited metabolic liver disease after, of course, correcting the gene defect by the gene therapy. And last but not least, they can be used for personalized pharmacological research. Now, to the end, what would be the take-home messages? First of all, the hepatocyte plasticity in vivo is the basis of liver regeneration in basal, acute, or chronic injury setting. In vitro, we have seen that the hepatocytes can convert due to their high plasticity to a proliferative fibroblast phenotype, or through a progenitor cell-like phenotype. It depends on the culture conditions that we use. Then in vitro, the hepatocytes can be substantially expanded in order to increase the numbers we need for regenerative therapy, but by doing that, we sacrifice the function. In vitro, the hepatocyte progenitor can be matured back to hepatocyte-like cells or cholangiocyte-like cells and used for regenerative medicine. But of course, a lot of studies are still needed in order to reach that goal. Thank you.
We have time for one question, and we'll save the rest for a panel, so we have time for Professor Rațiu. Maybe just a comment. I would wonder whether some of the desmin and the vimentin staining, or the alpha-smooth muscle and vimentin, actually represents an outgrowth of stellate cells, because they are very happy in culture, and they tend to grow better than hepatocytes. And they could actually be providing an important feeder layer that makes your hepatocytes happier. So it's worth exploring that.
Yeah, so this is a quick key question. What kind of cells are those? And the studies that have been shown so far is that those cells derive from albumin-producing cells. So the only albumin-producing cells in the liver is the hepatocyte.
Right.
So this one, taking all together and showing that this overexpression of EMT transcription factors, our conclusion would be that these come from hepatocytes.
Right. Okay. Good enough. So let's move to our final speaker before the lunch break, Professor Vlad Rațiu from University of Paris Hôpital-Salpêtrière and my former fellow. Vlad?
Thank you so much. So I realize this is a very complex topic, so I would like to simplify it. First, I'm very happy to be here and very honored to be part of this. This is a very nice slide that I borrowed from Brent Tetri, and it's intended to show how we handle substrate overload, in particular lipid overload and also glucid-based substrates. And actually what it shows is that the liver has a mechanism to deal with this increased amount of fatty acids that come from the food we eat. Basically, this is stored in the adipose tissue. And one of the things that go wrong in NASH is that the adipose tissue has lost its control over lipolysis. So basically what happens is that since insulin does no longer do its work, the adipose tissue will release a vast amount of these fatty acids directly into the liver. And that's how you end up with a part of steatosis, a large part of steatosis being originating from the adipose tissue. The second thing that is important that is shown here on the top part of the slide, over here, is that the liver has the capacity to transform glucids, so basically glucose and fructose carbohydrates into fat directly. And this pathway, which is called de novo lipogenesis, is particularly enhanced in patients that have NASH, actually is increased by a factor at least of 3. So these different mechanisms converge into an increase in the amount of fatty acids in the liver. And once this occurs, the liver set in place mechanisms that are able to store in a safe manner in triglyceride vacuoles, in steatotic vacuoles that contain triglycerides, this amount of fat. And this mechanism involves different biochemical reactions that end up with the synthesis of triglycerides. And genetic factors such as PNPLA3, which were mentioned in the previous talks, are probably important modulators of the interface between the lipid vacuole and the lipases, and therefore modulate the risk and the ability of the liver to store the lipids in the safe place, which are these triglyceride vacuoles. Now, there are only two ways for the liver to get rid or to dispose of the excessive fat, and these are basically burning the fat into the mitochondria through the process of mitochondrial beta oxidation here, or exporting the fat in the circulation through the synthesis of VLDL particles. So all these mechanisms seem to account, and which are very well understood, seem to account for the way we handle fat in the liver and the way we're able to store fat in a safe place in the liver. But of course, NASH is the example where things go bad. And the way things go bad in this whole paradigm in patients that have NASH is that the liver no longer saves fat in a safe way, but the presence of fat in the liver triggers inflammation and death cell injury that are characteristic of steatohepatitis, which we see in patients with NASH. And as much as we understand the mechanism of handling fat and the lipid flux in the liver, we understand much less what are the mechanisms that derail this whole system in favor of producing inflammation. So this is what I tried to figure here through this black box here, and I'll try in the rest of the talk just to highlight at a very high level some of the mechanisms that explain liver cell injury and inflammation-based consequences of liver fat accumulation in the liver. So I will focus on these different items here very briefly. First, lipotoxicity, cellular inflammation and insulin resistance. Then a short overview of some of the pathways of cell death and inflammation that might be operating in non-alcoholic fatty liver disease. The very interesting data on innate immunity and how this modulates inflammation and fibrosis. And finally, the crosstalk between adipose tissue dysfunction, because we have learned that most of the things that go wrong in this setting actually originate in the adipose tissue and not so much in the liver. So this slide here is intended to show how ER stress and mitochondrial dysfunction are being induced by the substrate overload, but also by some other intermediates such as cholesterol, which is known to have toxicity, and fatty acids. So basically what happens is that the amount of glucose and fructose that we consume will induce ER stress, and cholesterol and fatty acid directly or through interaction with cognate receptors such as TLR4 will also contribute to induction of ER stress and will contribute to the induction through the generation of reactive oxygen species of mitochondrial dysfunction. Then both ER stress and mitochondrial dysfunction will activate specific inflammatory factors, transcription factors that are important in the inflammatory reaction, and those are NF-κB and GNK. That will have as a consequence the setup of the expression of inflammatory genes that are characteristic of the steatohepatitis in the liver, but it will also have another very important consequence, which is that some of these intermediates, for instance, deacylglycerols, will interact directly with insulin receptor and therefore with insulin signaling. And therefore, these particular lipotoxic species will be responsible in large part for the mechanism of cellular insulin resistance. So these things here explain both the inflammatory pathways and the insulin resistance, and there are specific mediators, some of them related to lipotoxicity and the products of this whole lipogenesis cycle that I've shown on the first slide that are directly involved in the induction of cellular insulin resistance. So which are these particular lipotoxic species? A lot of focus has been focused on ceramides. There's some research, and especially some recently published data, which are really very interesting because, first of all, they show how important ceramides are both in the liver and in the adipose tissue. There is a constant crosstalk between the amount of ceramides in the liver and in the adipose tissue. And studies have shown that if we're able to deplete in an acute manner the amount of ceramides in hepatocytes, and both in hepatocytes, but also in adipocytes, and both experiments were done separately, these will have consequences that will first be, of course, visible at that particular tissue, but also in the other tissue. So if you do it in the liver, you'll have consequences in the adipose tissue. If you do it in the adipose tissue, you'll have consequences in the liver. And basically, these consequences are that if you lower the amount of ceramide, that will improve insulin resistance, both in the adipose tissue and in the liver. It will attenuate the inflammation in the adipose tissue and also the fibrotic reaction. And it will improve in the liver steatosis, and it will reduce the uptake of fatty acids in the liver. So ceramides, which are a byproduct of lipogenesis, seem to be important mediators both in the inflammatory and possibly the fibrotic reactions, but also in the modulation of insulin sensitivity. So, and many human studies have shown, for instance, that people with diabetes have an increased amount of ceramides both at the tissue level and at the serum level. So other intermediates of the lipotoxic, of lipogenesis, other lipotoxic subspecies are also involved, for instance, lysophosphatidylcholine that is shown here, are involved in other mechanisms of cell death injury, for instance, apoptosis. So we won't have time to go into this into detail. So the basic point of this first part is that we're trying to identify what particular byproducts of lipogenesis might be involved in modulating the inflammatory response in the liver and in also contributing to cellular insulin resistance. The second thing I would like to highlight is what are the pathways that account for cell death and how is this related to inflammation, in particular in non-alcoholic steatohepatitis. So this is, of course, a complicated slide, but I think it can be quite fairly simply synthesized in the following way. So once this is the example of a process of cell death that is triggered by TNF and the interaction between TNF with its cognate receptor, which is TNF receptor that is shown here. So once this interaction here between the cytokine and its receptor is being done, one of the downstream cellular consequences is the activation of RIPK1. RIPK1 is a very important molecule that sits at the crossroad between apoptosis and other pathways of cell death, which I will detail later. So there are several scenarios possible, and according to these scenarios, the cells will die in a different way, and the consequence on inflammation will be different. One of the scenarios is that RIPK1 gets ubiquitinated, and this will downstream activate NF-kappa B, and which will trigger the expression of inflammatory factors. Another way that things can happen is that RIPK1 can bind with caspase 8, activate caspase 8, and this will result in apoptosis, which is a form of cell death associated with very low amount of inflammation. Now, the third scenario is that in some situations, caspase 8 are inactive in the cell or are unavailable, and in that case, the pathway will follow a very different road, which is called necroptosis, and RIPK1 will activate RIPK3, and RIPK3 will phosphorylate another very important intermediate, which is MLKL, and this will steer the cell into a different way of dying, which is a necroptosis. And the difference between apoptosis and necroptosis is that the byproducts of this process, particularly the DAMPs, danger-associated molecular patterns, which are small molecules that are produced by this whole phenomenon, are produced in different amounts in these two scenarios, and this is what will be accountable for the level of inflammation that is associated with these different ways of cell death. So basically, apoptosis, low DAMP production, low inflammation; necroptosis, high DAMP production, high inflammation. And the reason I'm highlighting that is that there's a lot of new studies, I will highlight just a few a little bit later, which involve the necroptotic pathway in NASH, probably just to the same amount as apoptosis. Apoptosis in NASH has been described a long time ago. So basically, here are the three ways the cell can die: the canonical necrosis pathway, apoptosis, and necroptosis, their relationship with the production of DAMPs. And then you can see that most of the resident cells in the liver, so be it hepatocytes, stellate cells, macrophages, or the inflammatory cells that are bone marrow derived, can be affected to a different degrees by these different ways different pathways of cell death, and this will culminate into the fibrotic reaction. Now, the importance of this necroptotic pathway, which I just mentioned a little bit earlier this year, has been increasingly studied in NASH, and this is a very nice study that has shown clearly, if you look here, that NASH patients have a much higher expression of RIPK3, which is downstream of RIPK1, which is therefore a marker of the engagement of the cell in the necroptosis pathway, and it is upregulated in human NASH, and that this pathway mediates liver injury, inflammation, fibrosis, and the release of inflammatory factors in this inflammatory cell recruitment. You can see here that when you inactivate that particular pathway downstream enough, then the cells die less, and there's less inflammatory reaction, and there's also less fibrosis. So this necroptosis pathway seems to be operational and responsible of the inflammation fibrosis that we can see in steatohepatitis. Another important link between necrosis and inflammation is through the inflammasome. So basically, the inflammasome is a multi-protein complex, which main job is to trigger the activation of caspase 1, which is shown here. From procaspase into caspase 1. And why is it important to activate caspase 1? Because caspase 1, once activated, will promote the synthesis from their respective precursors of IL-1 beta and IL-1 D-suite. And in particular, IL-1 beta is very important, as I will show later, in the inflammation and necrotic cell death injury. There are several types of inflammasomes, which are shown here. This is one of them, NLRP3, that's another one here, and that's another one here, with different distribution, different tissues. Most of them seem to be operative in the liver, but what is particularly important here is that there are different upstream events that can activate the inflammasome, and some of them are particularly relevant to NASH. So I'm not going to go into each one of them, but you can see there are different highlights. A way to activate the inflammasome is through the production of ATP here. Another way to activate it is through different lipids that are synthesized during lipogenesis, through cholesterol, because we know that cholesterol, in particular free cholesterol, has cellular toxicity and accumulates in NASH as well. Another way, the third way to activate the inflammasome is reactive oxygen species, and all these culminate through different pathways that are specific to the same thing, which is the activation of NLRP3, which then binds to a different effector molecule, and that will promote the downstream events, procaspase to caspase 1, and then IL-1 beta activation. So then once you get IL-1 beta activation, this seems to be a very important cytokine in promoting inflammation, in recruiting the immune cells to the site of liver injury, in activating the stellate cells, and also in modulating the way the hepatocyte itself deals with the liver, with lipid flux, since it promotes steatosis and it triggers apoptosis and pyroptosis, which is another form of cell death. This inflammasome activation is central to each one of the important liver cell populations, hepatocytes, stellate cells, inflammatory cells. It occurs in each one of these cells through different triggers, but the net effect in each one of these will be the secretion of inflammatory intermediates, which will amplify the inflammatory reaction. The third thing I would like to highlight is the importance of innate immunity, which is something that hasn't been highlighted in the early studies of NASH, but becomes increasingly important here. So there are different types of inflammatory cells that migrate to the site of injury. You have neutrophils, monocytes, T cells, and their relative contribution and their direction towards the site of liver injury seem to be determined by the gradient of chemokine production at the site of cell injury. So you see here the difference, the different chemokines that determine here the recruitment of these inflammatory cells here. And Scott earlier told you about the therapeutic attempts in blocking some of these cytokines through specific inhibitors. Now, what is particularly important is to understand that the CD4 cells have a very strong plasticity, and actually they can differentiate in different subset populations that produce specific cytokines here. As you can see, each one of them have a specific cytokine shown here in red. But the most important ones for today are the Tregs and IL-17, which are two specific subsets of lymphocytes that can evolve from the naive CD4 cell. And what is particularly important is that, so to make it simple, Tregs are safe, and IL-17s are not good for inflammation. What is important is that the inflammatory milieu, which is shown here by one of the strongest inflammatory cytokines, which is IL-6, determines the switch from the bad to the good T cell population, so basically from the Treg to the IL-17. And then each one of these cells, of course, will secrete its own cytokines, but Th17 lymphocytes secrete many of the cytokines that, as I will show, are involved in the inflammatory reaction, in particular IL-17. So IL-17, which is secreted by the Th17 lymphocytes, will, through different intermediates, shown here, IL-16 and TGF-beta, will actually participate into the expansion of the own cells that produce them. So this is sort of a positive regulatory feedback. And in the presence of fatty acids, which there are plenty in non-alcoholic fatty liver diseased livers, that expansion of the Th17 cells will be further increased. The result of that is that the Th17 cell population will expand, will activate the inflammatory cells, the monocytes, and then IL-17 itself, which will be produced in excess because the population expanded, will have very important negative consequences, both in blocking insulin signaling, in activating the stellate cells, in activating the production of other inflammatory cytokines. Trying to move this faster, okay. Basically, all this will have important downstream cascade. This is not very responsive. Where should I point? Can you, okay. Next slide, please. Next one again. This will have will culminate in the accentuation of the inflammatory reaction and also the fibrotic reaction. Next slide. Okay, so the emergence of the importance of Th17 cells comes with the demonstration that in many chronic liver diseases that have an inflammatory component, you can see here hepatitis B, autoimmune hepatitis, and NASH as well, there is an increased number of IL-17 cells, producing cells in the liver. You can see here, and which is shown here, clear difference between normal controls, and this is human studies, and NASH, increased number of Th17 cells, and then increased production of the different cytokines that are specific to this subpopulation of T cells. Another important thing that further incriminates this subpopulation in the pathogenesis of NASH is the demonstration that people that are obese and have fatty liver have an increased number of IL-17 cells. And guess what? If you're able to reduce massively the weight of these people through bariatric surgery, you're able to revert the excess number of IL-17 producing cells towards a normal number seen in patients that have normal weight and no non-alcoholic fatty liver disease. So it's something that is clearly related to the presence of obesity and fat in the liver and can be reverted once you achieve weight loss. This has been reproduced, all this was in humans, this has been reproduced in animals as well. Animals that are fed a high-fat diet have an increased number of Th17 cells in the liver. They have an increased production of cytokines, especially of inflammatory cytokines, IL-17, IL-6, by this particular subset of T lymphocytes. And and if you take hepatocytes in vitro and you incubate them with fatty acids, you will get a steatotic cultured hepatocyte, but that process of steatosis production will be even further enhanced in the presence of IL-17. So IL-17 seems to be important in producing steatosis as well in animal models of NAFLD. Even more than that, IL-17 seems to be involved in fibrosis as well, because these are some very nice studies that have been published not long ago that show that independent of the type of the fibrotic model that is being used, and these here have nothing to do with dietary-induced fatty liver per se, because we're talking about bile duct ligation or CCL4 type of fibrosis models, there is an increase in the production of IL-17 and in the amount of IL-17 T cells. And if you were able to block these cells, and I think this is shown on the next slide. So basically, IL-17 expression increases with fibrosis, stimulates inflammatory cells, particularly Kupffer cells, and activates the stellate cells, the ones that produce fibrosis. Now, if you're able to disrupt that by creating mice that are unresponsive to IL-17 because they lack the IL-17 receptor, all these pro-inflammatory and pro-fibrotic action can be mitigated. And you can see here a reduction in all the inflammatory cytokines, in collagen production, in pro-fibrogenic cytokines as well. So IL-17 seems to be important in that regard as well. And some other studies that I will not comment here also show that IL-17 induces in the white adipose tissue neutrophil activation, disrupts insulin signaling, promotes lipolysis, which is again one of the main causes of increased fat in the liver. And it also blocks, blocking IL-17 reduces liver injury, improves insulin resistance, and also unexpectedly prevents liver cancer in these animals. So keep tuned about IL-17 in the future and Th17 cells. Now, what is particularly intriguing, you know that we now have, and I think Scott briefly mentioned that new drugs that are supposed to reduce lipogenesis are in development. And one of these drugs is quite advanced, is in phase 2, is an ACC inhibitor. So basically it disrupts lipogenesis, produces less fat, and helps burning fat. Now, what is particularly interesting is that high-fat diet and obesity in humans is associated with increased Th17 cell differentiations that we have shown previously, but is also associated with an increased ACC1 activity. And actually, increased ACC1 activity in the liver, I can show you here, induces the expression of a transcription factor, which is ROR gamma T, which is the main transcription factor that promotes the shift from CD4 naive cells to CD4 IL-17 producing cells. So this very interestingly makes the link between lipogenesis and how enzymes that are key in the lipogenesis chain will also have as a consequence the selection of particular subset of T cells, these Th17 cells that promote inflammation and fibrosis. And interestingly, in this study here, blocking ACC, not with the Gilead drug, but with some other chemical inhibitor, results in a reduced production of Th17 cells and an increased production of Tregs. And remember again what I've shown earlier, there is an imbalance between Th17 and Tregs in favor of Th17 in people that are obese and have NASH. So last part of my talk will deal with some fascinating data that show that the liver is not alone in this whole NAFLD context, and that the adipose tissue might be responsible for part of the inflammation that's going on in the liver. So we all know that there are, I would say, different ways of being fat and different consequences of obesity. Some people are fat and are totally metabolically healthy, and some people have disastrous consequences of obesity and insulin resistance. And it seems that what makes the difference between the two is the ability of each individual's adipose tissue to expand in the context of substrate overload. And this ability to expand can be either very important and particularly be operative in this peripheral adipose tissue, and then things go right, and the person is metabolically healthy, or it can be very limited, and the only compartment that can then expand is the truncal or visceral adipose tissue, which of course is numerically much less important and then has limited ability to expand. And in that situation then, the substrate cannot be all hosted in that particular compartment and will have to go elsewhere. And where does it go? Where it goes in the liver, it goes in the muscle, it goes in the heart. And since fat is not supposed to be in those organs, there will be very important consequences in the way these organs function. But one of the most important ones will be the creation of insulin resistance in those particular organs. So normally, this whole difference in the way we can expand in our adipose tissue can be simplified in the following way. The healthy person will be able to have an hyperplasia of the adipose tissue, so basically having more adipocytes to accumulate more of that incoming substrate excess. And that expansion of the adipose tissue in a healthy way will go together with the expansion of the vasculature of the adipose tissue, so no particular consequences here in terms of blood supply, hypoxia, etc. Now, the people that are unable to have that healthy expansion of the adipose tissue, instead of having a hyperplastic reaction, will have a hypertrophic reaction. So the adipocytes will increase in size, but not in number, and this will go together with a reduction in the increase in the vasculature, so more hypoxia. Who says more hypoxia says more inflammatory infiltration. Who says more inflammatory cells also says more fibrotic reaction. So these people will end up with an adipose tissue that is inflamed, that is fibrotic, that is insulin resistant. And all this is summarized by now a term that is being accepted, which is adipose tissue dysfunction. And some of the consequences of the adipose tissue dysfunction are highlighted here in the table. Now, this is something that can be very, very illustrative here. You can see the difference between healthy adipose tissue and inflamed adipose tissue, clear differences. We don't need to comment that. You can see what fibrosis of the adipose tissue looks like. But what is particularly interesting is that once you have an inflamed and fibrotic adipose tissue, the liver will start to suffer. And this is really groundbreaking work from Karine Clement's group at our institution, who have showed a very nice correlation between the hepatic complications and the hepatic inflammatory reaction and the infiltration of the adipose tissue, for instance, by macrophages, as it's shown here. And you can see that, and it's not all adipose tissue, it's particularly the visceral adipose tissue. And you can see here on this graph here that people who have the more severe type of liver disease also have the more severe inflammation in the visceral adipose tissue. And this has been shown in numerous ways. We don't have time to go into all these details, but take my word for it. The more inflamed the visceral, not the subacute, the visceral adipose tissue, the more there will be inflammation also in the liver. So it becomes particularly important to understand what is the crosstalk and what are the mediators that make this crosstalk possible between the two tissues. And there have been some very nice work that has shown using the different pathways analysis by microarray technology that show the complexity of the interactions between the inflamed adipose tissue and the inflamed liver and the number of genes that get turned on in the adipose tissue with the consequences, distal consequences at the liver level. I'm gonna skip that. So my last point on this particular aspect of the crosstalk is that not only is there a sort of an association between the two, but there seems to be a temporary relationship. And I find this particularly intriguing. Look here at these experiments, which have, this is a dietary model of NASH, and the authors look both at what happens in the adipose tissue and what happens in the liver in terms of inflammation and infiltration by inflammatory cells. And they looked at different time points of the dietary model. Early time points, 6 weeks, and then mid-term, and then late term, 26 weeks. And you can see that at 6 weeks, these are all the black solid bars here. Nothing much happens in the liver, while there is already an increase in those are different types of adipose tissue in the animal, okay? There's already an increase at early time points in the inflammation in the adipose tissue, but nothing in the liver. But then as time goes by and the model continues and the inflammation in the adipose tissue continues, you can see clearly an increase in the inflammation in the liver. So this tells you that there's a temporal sequence and that probably part of the inflammation originates in the adipose tissue and then translates to the liver at later time points. So there seems to be a dependency upon the adipose tissue inflammation that explains the liver inflammatory pathways. So in conclusion, and I hope I wasn't too long or too simplistic, it's absolutely impossible to really have an overview of NASH pathophysiology nowadays in only 20 minutes. But I think I wanted to highlight some of the things that are not usually addressed into the reviews on NASH pathophysiology. In conclusion, what I would say is that of course, NASH is a part of a cluster of metabolic disease that's characterized by insulin resistance, adipose tissue dysfunction. The key word here is lipotoxicity. It is important to understand which particular intermediates and lipotoxic subspecies are responsible for liver damage. What is the role of innate immunity in liver damage? The importance of Th17 cells and the blockage of Th17 cells. I took away the slides on other lymphocyte subpopulations, but those can be important as well. And all this information about the metabolic regulators, the anti-inflammatory, the inflammatory pathways, and the way fibrosis is being triggered in NAFLD, as has been shown earlier, are slowly evolving into the design of pharmacological agents that can block one or more of these pathways. And of course, it remains to be seen whether we need to block one of these or several of those together in order to be efficient and to control for the steatohepatitis process in patients with NASH. Thank you.
That was a beautiful overview. Thank you, Vlad. We have time for a couple of questions, either for Dr. Ratsiu, or I can take a question as well since we moved on. Yes, Professor Sarin? There's a microphone coming.
I have two comments, one for you and one for Vlad. In your very beautiful mechanistic part for NASH and the new drugs, somehow I did not see a mention of TNF-alpha inhibitors. One of them has been pentoxifylline, and another one was metformin, that is an insulin sensitizer. I just want to bring to fact that way back in 2004 and subsequently several studies, we showed that pentoxifylline inhibits TNF-alpha, starts insulin sensitivity, And believe me, when we do pre and post biopsies, the fat has totally gone and the fibrosis reduces. Also, it decreases the portal pressure. So I was wondering whether it needs further evaluation. And for metformin also, there is a significant reduction in fibrosis in NASH cirrhosis. One is the NASH, one is once fibrosis has occurred in portal hypertension.
Right.
And both these were ASLD presentations. I need your comments,
Sure.
whether they are any relevant or not.
Right. So there is two answers to the question. One is the scientific answer, one is the practical answer. From a scientific perspective, blocking TNF signaling has merit, but it's probably too blunt an instrument. Certainly we know that TNF alpha antagonists that have been developed for, let's say, alcoholic hepatitis have been fraught with terrible infectious complications, and that's always the balance in blocking TNF alpha, is incurring the risk of infection. I think downstream mediators like J and K are more appealing in mediating or attenuating cellular stress, which Vlad referred to. Pentoxifylline in particular, in my view, has no path forward because of its failure in alcoholic liver disease, the lack of appetite for, and the lack of strong rationale, I would say, compared to some of the other drugs. And the practical issue is who will pay for these trials, since, you know, a lot of the times drugs like metformin, which also makes some sense, have a difficult path forward because they're generic drugs. And so the reality is, unless it's a government or some other agency, private companies are not going to invest in a clinical trial to use a drug that's generically available and costs pennies, even though there may be a strong rationale. So that would be my answer. Makes sense in principle, in practice, not likely to happen.
Yeah, it was for repurposing the old drugs. And one, Vlad, you have beautifully shown the role of Th17. That's also the pathway for alcoholic liver disease. And Th17 has a lot to do with even neutrophils, not merely macrophage. It's like a pleiotropic cytokine which is double-edged. And one of your slides you showed that first it stimulates the neutrophils and then it goes to the monomax and macrophage pathway. So I'm not very sure in the pathogenesis of NASH, is there a role of neutrophil as an immune cell, or it has to go through the macrophage pathway? And if so, what is the mechanism by which Th17 directly goes to the macrophage pathway?
I'm not sure we can really dissect the respective role of these inflammatory cells, but clearly the original description of NASH included neutrophil infiltration. Now, it is striking that now that we've seen more patients with NASH, we start seeing differences between alcoholic liver disease and acute alcoholic hepatitis and NASH. And one of the differences is the amount of neutrophil activation and infiltration of the tissue. To make it simple, the more there are neutrophils, the more it looks like alcoholic hepatitis. And the same for Mallory bodies, by the way. So it might be that neutrophils have a minor role to play in NASH, but a much more important role to play in alcoholic liver disease. I cannot comment on how the direct way, the way IL-17 will direct rather neutrophil infiltration or the monocyte recruitment of cells, but I think all this is work in progress. And one of the difficulties in all these issues, as you know, is the fact that all these cytokines do not act in isolation. So there's a whole network of cytokines that can take over once you block one or the other. So it'll be very difficult to really understand the respective part of them. I would have a question for Scott. The whole field in NASH therapeutics tends to focus a lot on treating cirrhotic patients with NASH, because supposedly that's where the best bang for the buck would be, and the most benefit in terms of natural history progression, but also the best cost effectiveness ratio, and the higher the chances for reimbursement for these drugs is the cirrhotic population. So even if we leave aside issues related to toxicity, which clearly are increased in patients with cirrhotics, there are issues related to efficacy. And it strikes me that actually all of the studies that have been conducted in cirrhotic patients with NASH have been negative. And most of the studies try to revert fibrosis, among other things, in patients with cirrhosis. Some of them looked at portal pressure, no clear results, no clear reversal of the fibrosis stage within a short time period in cirrhotic patients. So can you make a comment whether we're not going into the wrong direction in trying to tackle this disease at the very advanced stage, and a comment about what mechanism account for an irreversibility of the fibrotic scar, or at least of the inability of the current compounds to find against that?
That's a great question, and you laid out perfectly why companies are reaching there, plus you can do clinical trials with hard clinical outcomes. But it also illustrates, which is true also in cancer, which is that drugs work a whole lot better in rodents than they do in humans. And there are two reasons. One is old, one is new. The old explanation for why animal studies are more favorable is because the nature of the scar is different in a short-term animal model where you have 6 weeks or 12 weeks of a drug that leads to cirrhosis. You don't have anywhere near the cross-linking, the loss of cellularity, the loss of LY6E low macrophages that Kostika talked about. All of those events are not nearly as advanced in a rodent cirrhosis model as in a human cirrhosis. And then the second reason, which I think is absolutely fascinating, there was a paper shown earlier in the Delta hepatitis talk by Barbara Rehrman. She's more recently done a fantastic study in Cell last year in which she collected wild mice from the community around the NIH and compared their microbiome and their response to disease perturbations to laboratory inbred mice. And what she showed was that wild mice have a much more complex microbiome, and they are much more resilient and resistant to animal models of disease and stress. They didn't use liver models, they used others. And they could confer that resistance to disease to an inbred mouse if they transferred the microbiome. So I think what that tells us is that inherently the animal models we use are much more susceptible to disease and much more susceptible to responding to a rational therapy. So I think when we see an animal model that has a modest response to a drug, we should rethink whether that increment of potency is sufficient enough to also make it active in humans. So far the answer consistently has been no. There isn't a single drug that can reverse cirrhosis. The second part of my answer quickly is that we really, of all the different areas around the biology, the one we know the least about still is the features and the effectors of matrix degradation. The best we have is animal studies looking at subsets of macrophages. We have no idea what they correspond to in humans. We don't know what they generate. We can't amplify them. So if we were really trying to give a fibrolytic therapy, which is what's needed in cirrhosis, we don't know where to start. And I think those are at least a couple of reasons why your comments are absolutely appropriate, that aiming for cirrhosis is a very high bar, and there will be a lot of failures. If there is a success, I believe it will be a drug that's not just antifibrotic, but also strongly pro-regenerative, because the regeneration response itself carries with it an inherent antifibrotic or fibrolytic activity. So,
thank you.
I think in the interest of time, Vlad, we probably should wrap it up because I know there's a lunch program as well. I want to thank all the speakers and Professor Gheorghe and the organizers for including us. Thank you.
I invite you all before lunch to have to join us to the Gilead Symposium and to try to find out how to optimize ACV therapy across all disease stages. Oh, sorry. No, sorry. No, it's. No, what happened? Oh, okay, I'll start by Craig's presentation. A female, 68 years old, diagnosed with hepatitis C in 2014 when she was admitted to hospital for an acute myocardial infection. Then she had a stent placed, and she was also evaluated for fibrosis. Then she had just F0, F1 metavir according to FibroScan, steatosis, mild to severe, positive viral load, genotype 1b. I want to stress that she had associated diseases like arterial hypertension, previous episodes of arterial fibrillation. Now she had discovered stent, coronary stent. She associates also type 2 diabetes, mellitus. She has also chronic hepatitis B on treatment, osteoporosis, gonarthrosis, autoimmune thyroiditis with hypothyroidism, recurrent vertigo, and insomnia. Should antiviral therapy be extended to these subjects with old age and or extrahepatic comorbidities, since both conditions compete for mortality in patients with ACV mild liver disease? In 2014, for sure, we won't treat her. But in 2019, for sure, we will treat her. Now, according to all the guidelines, all patients should be with hepatitis C should be treated no matter what fibrosis stage they are, from F0 to decompensated liver cirrhosis or after liver transplantation. About our patient, to treat or not to treat this patient with mild fibrosis in an old patient, there are for sure risk factors associated with faster fibrosis progression in hepatitis C, but when a patient had mild disease, we don't know for sure what factor leads to a fast progression or what associated factor leads to a smaller, slower progression, and that's why we have to treat even in mild fibrosis stages. Many studies have indicated that treating patients with hepatitis C reduces all-cause mortality regardless of stage fibrosis. And also, least but not last, probably, there are a lot of pharmacoeconomic studies that showed that eradication of hepatitis C is cost-effective also in mild stages of fibrosis, no matter what are the prices of drugs. What treatment would you choose? For sure, I would choose this ledipasvir sofosbuvir therapy because it showed in many studies that have a lower number of DDIs compared to all the other medication that we can use up to now in Romania. Sofosbuvir ledipasvir is available now for all fibrosis stages, also here in Romania and all across the world. And these are the clinical pivotal studies, ION 1, 2, 3, and all the ones that were published since 2014. I'll just stress some of them. ION 1, that it's an open-label randomized phase 3 trial that used a fixed dose of ledipasvir sofosbuvir plus or without riba for 12 or 24 weeks in 99 sites in the United States, in Europe, and this is a design of the trial. It was randomized, as I said, performed in 865 patients. It was meant to evaluate the length of therapy and the need for riba. Regarding the baseline characteristics, I want to stress that there were mainly males with over 50 years of old. Cirrhosis was present in less than 20% of cases. Most of the patients were genotype 1A, and they have rather high viral loads. The efficacy was very good. 12 SVR rates were 97 to 99% across all study arms, with no differences in SVR based on length of therapy, use of riba of genotype 1 subtypes, and there was no difference in SVR 12 rates in those with cirrhosis versus those without cirrhosis. What are the reasons for not achieving SVR? There was just one breakthrough due to non-adherence, and I want to stress that SVR12 was very good, even the patient had NS5A resistance at baseline.
and this didn't lead to virological failure. Also, these drugs are safe with very low serious side effects, no death. And in conclusion, ledipasvir sofosbuvir for 12 weeks achieved a very good SVR rate in treatment-naive patients. Adding RIBA and or extending the treatment to 24 weeks is not needed because do not increase the SVR rates, and baseline NS5A mutations in a minority of patients did not impact high SVR rates. And also it's very well tolerated. Only the addition of RIBA contributed to higher incidence of side effects and laboratory abnormalities. The ION-2 study was designed to investigate if a fixed dose of ledipasvir sofosbuvir with or without RIBA for 12 or 24 weeks was efficient in treatment-experienced patients with genotype 1 ACV. This is the design of the study. It included 440 patients. Again, there are predominantly male patients with age over 50 years old, high viral loads, predominantly genotype 1A genotype. Cirrhosis was present in only up to 20% of cases, and over 50% of patients were prior treated and failed previous inhibitors. Again, the efficacy is almost perfect, over 94% of cases, no matter if the patient received 12 or 24 weeks of therapy with or without RIBA. Again, the reasons for not achieving SVR was just one breakthrough due to non-adherence, and again, NS5A resistant variants or NS3, NS4A resistant variants did not impact the SVR rate. The safety was good, just more serious side effects in the groups with a higher length of therapy and with RIBA added. In conclusion, ledipasvir sofosbuvir for 12 weeks resulted again in very high SVR12 rates in genotype 1 patients who had failed previous pegylated interferon plus or minus protease inhibitors. Also, baseline NS5A mutations did not impact high SVR rates and is very good tolerated. ION-3 was a phase 3 study that compared 8 weeks versus 12 weeks of therapy with ledipasvir sofosbuvir in treatment-naive non-cirrhotic patients with genotype 1 hepatitis C. Again, this is the design of the study. It included 647 patients, all naive, and baseline characteristics were mainly the same. Most of the patients had mild fibrosis F0 to F2 with low viral loads among 50% of them. Again, the majority were males and with a mean age over 50 years old. Again, the efficacy was very good, over 93%. No matter if the patient received 8 or 12 weeks of therapy with or without RIBA, and no matter if the viral loads were high or lower. However, it was a little bit higher failure rate in the patients that received 8 weeks of therapy with very high viral loads. Again, the safety was good, no side effects, severe side effects. Also, the variants did not impact the SVR rate. In conclusion, ledipasvir sofosbuvir for 8 or 12 weeks resulted in very high SVR rates in genotype 1 treatment-naive patients without cirrhosis. Also, the viral load, although it impacted a little bit the relapse rate, nowadays this viral load is not of any importance, and we can use safely 8 weeks of therapy in non-cirrhotic patients. And again, NS5A polymorphisms did not impact the SVR rate. Sirius is another study that was meant just for patients with compensated cirrhosis, and it again evaluated if 12 or 24 weeks of ledipasvir sofosbuvir plus RIBA is efficacious or not, and which is the best way to treat the patients with compensated cirrhosis. These are the baseline characteristics. Again, I just want to mention the high rate of genotype 1A patients with the high previous patients treated with protease inhibitors. Again, the efficacy is very good, and treatment experienced cirrhotics had a similar response to ledipasvir sofosbuvir plus riba for 12 or 24 weeks. The safety is good, and I want to mention that there was an overall improvement in liver function during these treatments, and a very good improvement of albumin, INR, and bilirubin. In conclusion, 97% of patients with previous failure to protease inhibitors and cirrhosis achieved an SVR12. No matter if they received 12 or 24 weeks of therapy, there was very good tolerated therapy, and if adding riba, it may result in higher SVR rates among patients with previous treatment experience. I want just to stress that also in adolescents between 12 and 17 years old, there is a very good safety and effectiveness of ledipasvir sofosbuvir, and there are ongoing studies in children less than 11 years. This is the study design. There were 80 naive patients treated with genotype 1. In this arm was just one patient with cirrhosis and 20 patients with treatment experienced non-cirrhotic adolescents. The SVR rate was excellent, and again the safety was good. Administration of ledipasvir sofosbuvir in adolescents provided comparable plasma exposure to sofosbuvir and pasvir compared to adults, and all patients with baseline NS5A and NS5B polymerase inhibitor RASes were treatment naive, and again all achieved SVR12 rates. So in summary, ledipasvir sofosbuvir was highly effective in treatment adolescents, and dosing of ledisof currently used in adults was well tolerated and had comparable PK exposure. So in summary, sofosbuvir ledipasvir is a good choice to treat all stages of fibrosis, all ages, even if they are treatment experienced or not. Thank you.
So thank you very much. In the second part of this Gilead symposium, and I'm deeply, I want to thank you for your support, and I'm deeply engaged in this presentation. I would like to present how the success actually look in real life. And these are the outlines of my presentation. I will cover these three objectives. Actually, I will briefly comment on the importance of real life data, and then I'll extensively present the ledipasvir sofosbuvir experience in real life and in genotype 1 patients to finally update our clinical case. Well, in modern era, we based our treatment decision in ACV patient on level of evidence. This is true in all the things, but it's true also in our patients with ACV infection. If you look at this pyramid of evidence, you can see that on the top there are systematic reviews and meta-analysis, and also the direct comparative trials. These are a huge level of evidence, but they are few in the literature. Not all of them are of good quality, and not easy to be performed and accepted sometimes by the side of the industry. The second level of evidence consists in phase 3 randomized controlled trials. As you know already, these are considered the gold standard for evidence and usually lead to the approval for clinical practice of a new regimen or a new indication. But there are some gaps between clinical trials and clinical practice. And the major of these are the low number of patients enrolled in clinical trials. Many times these are selected homogeneous patient population. There are also selected prescribers, a dedicated protocol, a carefully pre-treatment assessment and on-treatment monitoring. These are also short-term studies, and the treatment benefits and harm in the medium and long term are not followed. Also, the impact of adherence in the long term is not assessed in these clinical trials, and many times real-life experience has been proved to be very different than those predicted in clinical phase 3 trials. Then the phase 2 post-marketing real-world studies are cohort and case control studies dedicated to capture the growing experience in clinical practice in real world, to confirm the results of clinical trials in real world, and to provide also additional outcome data on these new regimens. And the major benefits gained from phase 4 real-life data, they support the results of clinical trials. They show how these drugs behave in real life on a large number of patients, on a complex and heterogeneous population, add to the safety profile of these drugs, and provide knowledge on long-term benefits and also risk, as you have seen in the last trial about hepatocellular carcinoma risk or portal hypertension progression. Also, I can say that nowadays the practitioner, the practicing hepatologist is facing with challenges and limitation in treating ACV patients in real life. As you can see, we have a heterogeneous population of patients in heterogeneous clinical settings. Regarding the demographic, the complexity of clinical settings, for example, HIV co-infected patients, or patients with chronic kidney disease, or patients after liver transplantation, and so on. We have treatment experience patients or patients with failures, multiple comorbidities in this patient, or patients who take chronic medication. Patients with advanced liver disease represent also an important challenge in real life, as you may admit that we have a heterogeneous pool of prescribers concerning their experience and expertise, and also a limited infrastructure and human resources in this regard in the real world. I will focus over the next minutes on the ledipasvir, sofosbuvir genotype 1 real-life cohorts, trying to answer these questions, how the success looks in real life. And as you can see in this slide, we have many cohorts, a growing experience in real world, many cohorts across the world supporting the data that you already know from clinical trials. Many of these cohorts are very important because they bring us many data about genotype 1 patients, and the more representative of these cohorts I sum up in this slide. And you can see here the IFI cohort and German hepatitis C registry, then Spanish Hep-C cohort, the Kaiser Permanent, Burman's Pharmacy, Veteran Affair, and Baltimore Veteran Study, and also ACV and TRIO, ACV Target and TRIO cohort, all of them from mainly from the United States, as well the pool 8-week data from the literature. So I'm going through many of these real world cohorts, trying to show you data supporting the high efficacy of the 8 and 12 weeks regimens with co-formulated ledipasvir, sofosbuvir, as well as the real-world data supporting the high efficacy across of this regimen across different patients' population. What you can see here, it's ACV target trial, which actually represent a huge database, huge experience in clinical practice, in real world, on more than 2,225 genotype 1 patients who received ledipasvir, sofosbuvir plus minus ribavirin in real world. This was a multi-center prospective observational real-world study at academic and community centers in North America and Europe. As you can see here in this slide, there were many naive but also experienced patients, half and half practically. One aim, the vast majority of these patients, because it was conducted especially in the United States, cirrhotic patients, almost, as you can see here, 58%, and a minority of patients with the compensated liver transplantation and HIV co-infection. And here are the results of ACV target, as you can see. You can see here data also for 12 weeks, 24 weeks, but also for 8 weeks with ledipasvir, sofosbuvir, an overall sustained virological response, as you can see here, of 96-97 across all these regimens, confirming in real world the good data that we have from clinical trials. And this is also true not overall, but also in different subpopulations, such as non-decompensated or non-cirrhotic patients, cirrhotic non-decompensated and non-cirrhotic patients, ACV RNA above 1 mil, genotype 1 experienced patients, prior liver transplantation, and patients who received PPI during the treatment. The safety profile was also good. As you can see here, the most encountered adverse events were fatigue and headache. You can see a lot of mild adverse events. Most common of them in proportion of 22-25%. There were 11 deaths during the study in 10 patients with cirrhosis and 6 with compensated cirrhosis. And there have been significant differences between ledipasvir, sofosbuvir regimen and ledipasvir, sofosbuvir and ribavirin regarding, of course, histologically anemia, dyspnea, and rash. The conclusion of this study, ledipasvir, sofosbuvir containing the regimen for 8 weeks or 12 weeks is highly equally effective across a broad spectrum of genotype 1 infected patients and clinical practices. The 8-week regimens is for sure underutilized because only 41% of patients qualified for this regimen receive actually 8 weeks of treatment. Discontinuation rates are very low, below 2%, despite the diversity and complexity of patients in clinical settings. And the following factors were associated with higher relapse rate: cirrhosis, genotype 1A, liver transplant recipients, compensated cirrhosis, and patients treated with PPI. This is the second real-world cohort that I want to present to you. It is the German hepatitis C registry. Let's take a look at this real-world observational study on a huge number of patients, more than 2,000, 2,500 of patients, genotype 1, treated also for 8 or 12 weeks with vetipasvir, sofosbuvir, plus minus ribavirin. As you can see here, the same important high rates of sustained virological response in 8 weeks, 12 weeks, or 12 weeks with ribavirin, 98, 99, 97%. These are the rates of response in this patient. And the conclusion was that the real world ledipasvir, sofosbuvir for 8 weeks resulted in similar rates of sustained virological response as ledipasvir, sofosbuvir for 12 weeks or ledipasvir, sofosbuvir plus riba for 12 weeks. This analysis individualizing the patients in special categories, HIV infected, older patients above 70, and patients on opioid substitution therapy show great figures, as you can see here. Again, in between these groups, patients with HIV or without, older or younger than 70, or patients on OST or no, you can see the same important figures of sustained virological response above 96%, as you can see here. And we can say in conclusion here that under real-world conditions, the same regimen, ledipasvir, sofosbuvir, for 8 weeks results in comparable sustained virological response rate to 12 weeks. Also in patients HIV co-infected, older individuals, or patients on opioid substitution therapy. This is also a German study, a German real-life cohort in a single center in Germany, comprising the 103 primary naive, non-cirrhotic genotype 1 patients with baseline ACVRNA less than 6 ml per unit per mil, treated with ledipasvir, sofosbuvir for 8 weeks. As you can see here, the sustained virological response is excellent, it's perfect. You can see here 100% in all patients, and also in a very small group, 3 patients HIV co-infected. And the conclusion is that the real-world regimen ledipasvir, sofosbuvir for 8 weeks resulted in a high rate of sustained virological response and was well tolerated in mono-infected and also in co-infected HIV co-infected patients. Here is the Hep C Spanish study, ledipasvir, sofosbuvir, also for 8 weeks in Spanish genotype 1 patients from a real-world setting. More than 2,000 patients again treated for 8 weeks with the same regimen. You can see here many patients in F4, many patients in F4, more than half of these patients, treated mainly with a 12 weeks regimens. And you can see here the efficacy results showing 98% in both regimens, sustained virological response. And one comment that I have here is that only 20%, 1 in 5 patients qualified for 8 weeks therapy actually eventually receive 8 weeks therapy in this Hep C trial. So in real world, ledipasvir, sofosbuvir for 8 or 12 weeks results in similar rates of sustained virological response, and for real-world cohorts coming from the United States. This is Kaiser permanent study conducted in Northern California, looking also at the efficacy and safety of the ledipasvir sofosbuvir regimen plus minus riba for 8, 12, or 24 weeks in a large integrated healthcare system in Northern California. Also, an important number of patients, 1,200 genotype 1 patients treated with this regimen for 8, 12, or 24 weeks. And as you can see here, the per protocol sustained virological response was quite high, above 92% in this patient, irrespective of the duration of the therapy. And therefore, the conclusion is high sustained virological rate in between 90 to 95 in genotype 1 patients treated with ledipasvir, so sofosbuvir-based therapy, irrespective of treatment duration, 8 or 12 weeks, and irrespective of the presence of ribavirin. Here is a trio trial, also conducted in many settings, academic and community centers in the United States. A real-world observational study on 895 genotype 1 patients treated also with ledipasvir, sofosbuvir plus minus riba for 8 or 12 weeks. As you can see here, the demographic features are very characteristic for the North American population. The vast majority of patients were Caucasian. The genotype that predominated was 1A, and the vast majority of these patients had a low viremia as defined for the study below 6 million units per minute. And what you can see here is the result of efficacy, ledipasvir, sofosbuvir for 8 weeks or 12 weeks. The green, respective the red bars, irrespective of the subgenotype or the stage of fibrosis or the level of viremia of these patients experience a high sustained virological response, as you can see here. And overall discontinuation rate was below 1%, so the conclusion is high sustained virological response in between 94 and 100% in genotype 1 patients treated 8 or 12 weeks with ledipasvir, sofosbuvir, and this is irrespective of subgenotype, stage of fibrosis, or viremia. Also, this study looked at the patients, the effect of proton pump inhibitor used on virological response in a cohort of patients from trial, 2,034 patients, and as you can see here, in the overall sustained virological response is no difference in between patients taking or not taking PPI. If the prescribing information have been respected, and the conclusion of the study of this part of the trial is no impact on SVR of daily PPI, the proton pump inhibitors, in a heterogeneous and very complex real-world population in the United States when use this co-medication accordingly to ledipasvir, sofosbuvir prescribing information. And here is a Burman pharmacy data, a real-world study on 338 genotype 1 patients treated also with ledipasvir, sofosbuvir for 8 weeks. You can see here a sustained virological response confirming the efficacy, the high efficacy of this regimen in real world, 98%, no drug discontinuation in this population, and no significant adverse events reported. And the conclusion is high sustained virological rates, 98% in treatment-naive, non-cirrhotic, genotype 1, low viremic load patients treated for 8 weeks with ledipasvir, so fosbuvir, no drug discontinuation and no significant adverse report. Here is the same real-world study looking at the potential differences concerning the stage of fibrosis. And as you can see here, and this is the conclusion of this part of the study of this analysis, there are lower sustained virological rates only in F3 patients, in patients with advanced liver fibrosis, with the same profile that I have presented. And finally, the integrated real-world analysis pulling all the data from patients eligible to receive 8 weeks of ledipasvir, so fosbuvir, in several trials, German IFI, Berman Pharmacy, and Kaiser studies. And as you can see, excellent sustained virological response, 12 in between 98, 100%. And this is irrespective of the age of this patient, of HIV co-infection, of the race, or even viremia, subgenotype, and the stage of fibrosis. Real-life virological response in more than the previous 4 cohorts, in 13 real-world cohorts, including more than 6,000 patients, have been presented. In this slide, you can see as comparison all of this data with very high sustained virological response in between 92 and 100%. And this is this look actually in the same manner as the ION-3 data that my colleague previously presented. And finally, let's update our clinical case. So back to Our Lady. It is well known that ACD infection has a negative impact on the quality of life, especially in elderly patients. And what does fit the best? Our patient, our old lady, co-medicated. She is treatment naive, is genotype 1b, is non-cirrhotic, actually a good profile until now, but with cardiac comorbidities, with diabetes, but no renal involvement, and with 15 concomitant medications, so polypharmacy. And all of these interactions have been checked, as you can see here, no major interaction, no contraindication, only with atorvastatin and omeprazole. In these cases, the measures are only regular monitoring and respecting the information of the prescriber. And the patient received 8 weeks of sofosbuvir, ledipasvir, obtained sustained virological response, and looked happier and healthier than before. So these are my conclusion and the conclusion of this symposium, how the success looks in real life for these patients treated with ledipasvir, sofosbuvir. In real world, this regimen results in a high rate of sustained virological response in genotype 1 patient, the patient that are in our current care, patients with chronic hepatitis, with all fibrotic stage across a broad spectrum, including HIV patients, older individuals, patients on opioid substitution therapy, PPI user, and so on. Ledipasvir, sofosbuvir for 8 weeks is highly and equally effective with a 12 weeks regimen among naive genotype 1 patients but it's still underutilized in clinical practice. Below than half of these patients, qualified patients, receive actually 8 weeks of therapy, and discontinuation rates and serious adverse events are very low, despite the diversity, complexity, heterogeneity of these patients in clinical setting in real world. And with this, I thank you very much.